In what's been dubbed by Time magazine as the Angelina Effect, actress Angelina Jolie's recent public announcement about her decision to undergo a preventive double mastectomy because of a faulty gene has focused a spotlight on genetic testing and prophylactic mastectomy. I'm Jane O'Brien, and I've put together this video in an attempt to address some of the questions that I, as a specialist breast surgeon, have repeatedly been asked following Angelina's recent announcement, such as, could I have the breast cancer gene? Should I be having genetic testing? And even, can I have an Angelina? I think the first thing to emphasise is that whilst breast cancer is unfortunately a common disease, only 5 to 10% of all breast cancers are related to an inherited genetic abnormality, and less than 1% of the population have a mutation in one of the major breast cancer predisposition genes, BRCA1 and BRCA2. Whilst the average lifetime risk of breast cancer to age 85 for Australian women is around 10 to 12%, for the very small proportion of the population who do have a genetic mutation, the lifetime risk may be up to 80% or more, as well as a 40 to 50% lifetime risk of ovarian cancer. These women can face potentially life-challenging decisions whilst often at still a very young age. The BRCA1 and BRCA2 genes are tumour suppressor genes, which were identified in the 1990s. A normal cell has 2 functional copies of each gene. Individuals with a BRCA mutation have inherited 1 non-functional copy of the gene in every cell of their body. These individuals therefore require only 1 further hit or mutation to knock out the remaining functional copy of the gene, making cancer development much easier, and hence the development of cancer at a younger age. Both of the BRCA genes are inherited in what we call an autosomal dominant pattern, meaning that only 1 abnormal copy of the gene is needed to increase an individual's predisposition to breast and/or ovarian cancer, and there's a 50-50 risk for an affected parent of either sex to pass on the mutation to their children of either sex. The family history is therefore equally important on both sides of the family, not just the mother's, as is a common misconception. Mutations in the BRCA genes cause particular patterns of cancer down the generations. The estimated frequency of BRCA mutation carriers in the general population is around 1 in 1,000 people. The frequency in certain specific population groups can be higher. For example, in people of Ashkenazi Jewish descent, the rate of mutation carriers is 1 in 50 to 100 people. Features suggestive of a potential BRCA or BRCA mutation within a family are multiple cases of breast cancer on the same side of the family, often with early onset, such as age less than 40 years, ovarian cancer in a family with a history of breast or ovarian cancer, breast and ovarian cancer in the same woman, cancer in both breasts, certain ancestry, such as Ashkenazi Jewish, and male breast cancer. Women who are concerned about their family history and the potential risk of a BRCA gene can obtain more information on the Cancer Australia and Breast Care Network of Australia websites, and should discuss their family history with their general practitioner in the first instance, who will, if appropriate, arrange for onward referral to either a breast specialist or directly to a familial cancer centre, where a more formal genetic risk assessment can be performed. Another group of women in whom Angelina's announcement has raised questions are women with a recent diagnosis of breast cancer themselves. Certain breast cancer pathological subtypes are more common in association with BRCA mutations, and if, for example, a triple-negative breast cancer is diagnosed in a very young woman, genetics assessment may be indicated even in the absence of a family history. The identification of a BRCA mutation in a woman with recently diagnosed breast cancer can be very clinically relevant and significant, as it may have a significant influence on surgical decision-making, perhaps prompting the patient to make the decision to undergo bilateral mastectomy with or without reconstruction, rather than breast-conserving surgery or lumpectomy followed by radiotherapy. Genetic testing, which involves a blood test, is provided to consumers through familial cancer centres, which are generally co-located within public hospitals. Genetic counselling is a vital part of this process. Publicly funded testing is usually offered when there's felt to be a 10% or greater chance of a mutation being present. Consumers may also elect to pay for testing through private laboratories. However, it is strongly recommended that this be performed under the auspices of a genetic service to allow appropriate interpretation and explanation of the results by trained genetic counsellors. Genetic testing can open a floodgate of mixed emotions within a family. The range of psychological issues associated with genetic testing highlights the importance of both pre- and post-genetic counselling as a key component of the process. For women in whom a BRCA mutation is identified, various risk management strategies are available. The precise breast cancer risk for an individual woman will vary according to several things, such as her age, the number and age at diagnosis of affected family members, and the exact nature of the fault in the gene. The main options to manage breast cancer risk are surveillance, risk-reducing medical therapy, or prophylactic double mastectomy, the most effective form of prevention. There are many factors that may affect a woman's choice. For example, how old she is, whether she's had or planning to have children. As there's no effective form of screening for ovarian cancer, there's a recommendation for BRCA carriers to have the ovaries and tubes removed at around age 40 or after childbearing is complete in order to reduce the risk of ovarian cancer. And if this is performed prior to the menopause, it in addition also reduces the risk of developing breast cancer by up to 50%. Intensive breast surveillance is recommended, which involves regular clinical breast checks and yearly screening with mammography, perhaps ultrasound in addition, and more recently also MRI scanning. Research has shown that MRI can pick up cancers early, even in young women in whom breast density limits the sensitivity of mammography. This has not, however, yet been shown to improve survival, and MRI also unfortunately has a high false positive rate, meaning it picks up many non-cancerous changes. In 2009, the Australian government introduced a Medicare rebate for MRI screening for women who are at high risk of developing breast cancer. This is currently the only situation in which breast MRI is subsidised, and eligibility criteria are fairly strict. Women must be under the age of 50, fall into a high risk category as determined by specified family history criteria, and the test must be ordered by